Hello, everybody. Today we'll be discussing about our case analysis. My name is Michael.
Steven?
Cat. Ow.
All right. And we will begin with our scenario first. So our scenario goes, 58-year-old white man, well known and liked by the staff at the Samaritan Shelter for the Homeless. The social workers at the shelter have spent a great deal of time and resources working with the man on a number of areas, including his alcohol addiction. Their records show that they have not seen him for about 6 months. When they last saw him, he was not drinking, he had a secure job, and was making enough money to eat and pay rent on a small apartment. The staff members were saddened when he came to the shelter in search for some food and bed. The man appeared tired, dirty, and depressed. He smelled of alcohol. He stated that he had quit his job about 3 months previously because his boss was a jerk. He also confirmed that he had been living on the streets again because of the inability to pay for rent. Although he chain smoked as he talked to the staff members, he frequently complained about his smoker's cough. 2 days after he arrived at the shelter, he began having episodes of coughing that were more severe than usual. On several occasions, the coughing spells lasted more than 2 hours. When the staff members at the shelter noted that the man expectorated about a pint of fresh blood, they decided to transfer him to the local charity hospital. Although the man initially resisted, he finally agreed to go to the hospital. In the ER, the man appeared anxious, chronically and acutely malnourished, weak, and in obvious respiratory distress. His nail beds were cyanotic, and his fingers were yellow from nicotine stains. The patient stated that he had smoked approximately 30 cigarettes a day for 35 years. He had frequent strong cough, producing moderate amounts of yellow sputum mixed with small amounts of fresh blood. He stated that his cough has been getting worse and he thought that he probably had a cold. He also indicated that he could not seem to get his breath. The patient denied having any respiratory problems before this admission. However, he also stated that coughing up blood was no big deal because he had done it before. Although the patient denied having used alcohol for months, the staff members from the shelter documented the smell of alcohol at the time of his admission at the shelter. So going into our patient assessment, we first go into our subjective. There weren't really as much, as the patient did complain of coughing, shortness of breath. He did deny any respiratory problems prior to his admission and having used alcohol for months, although the staff member did note that he has been using it for some time. He also smoked approximately 30 cigarettes a day for 35 years, and he also stated that he coughed up blood. That was no big deal because he's done it before. And now moving on to objective, I hand it over to Kat.
So for the objective, we do know that he is a 50-year-old male. He is homeless. He has an alcohol addiction. He is a chain smoker. He's been coughing up blood. He's malnourished. He's in respiratory distress. He's cyanotic. They did his vitals, which is a heart rate of 110, which is high. The blood pressure is 170/95, which is also high. His respiratory rate is elevated at 26 breaths per minute. His temperature is 101, which is high. His breath sounds, he had bronchial breath sounds all over the right and left lung bases. He also has crackles and bronchi noted on the right upper lobe, and he has a pleural friction breath as well. They did a complete blood count. His hemoglobin is 17 grams a deciliter. His white blood count is 14,000. They also did an ABG. His pH was 7.53. His CO2 was 51 torr. His bicarb was 41, and his PaO2 was at 50. They also did an X-ray on the man. He had increased opacity. They also saw a cavity about 5 centimeters on the left lobe, and also they did a Mantoux test, and his carboxyhemoglobin was at 8.5%. Like I said before, they did do the Mantoux test, which is also known as, the skin test, as we know because we had to get it for clinicals. So there are 2 types. There are the skin test. And so this is what the negative, the kind of doubtful, the positive, and the allergic. So for negative, it's slightly red. It's basically completely gone by the time they go and check it. For the doubtful, it's still reddish. They might not see the actual wheal, how they say it, on the arm, but you can see a little redness. For a positive, the diameter of it, it's bigger than the ones I just mentioned. As you can see, it's a lot bigger. So they might have, even though it's a positive, they might have a weak, an average, or a strong reaction, as you can see in the images. Or if they have, people actually have allergic reactions also to the skin test, and that's where you see it's a lot bigger in diameter, and also you can even have pus in the site. And then the other one that they test is the quantiferum testing. So for that, it's a little different than the skin. So the skin test, you have to actually go back after like 48 to 42 hours. For this one, it's just one time and you're done. So they actually draw blood from you, and they send it to the lab, and they check for any response to specific TB antigens. And that's how they tell if you're positive or negative. And for that one, they either know that you're positive or know that you're negative, not like the skin one where it can be doubtful as well.
For our assessment, we diagnosed the patient's main issue to be tuberculosis. Why? Well, for a couple of reasons. First one, 101-degree fever, trying to fight off an infection. The 5-centimeter cavity in the left upper lobe, which is a staple of TB. The white blood cell count of 14,000, which is increased. And the sputum, which was hemoptysis. Patient had moderate hypoxemia with a PaO2 of 50 millimeters of mercury. Of course, the crackles attributing to that, SpO2 of 88%, and elevated carboxyhemoglobin levels at 8.5, with our normal range being under 3%. Our ABG was a partially compensated metabolic alkalosis. The patient presentation, however, leads me to believe that this is an acute metabolic process on top of a chronic lung issue. With the patient's respirations being 27, we suspect that the normal baseline CO2 must be a lot higher instead of our normal range of 35 to 45. Reasons for this ABG could actually be in part to vomiting, causing hyperchloremia, result of drinking. We need an ABG with lights to confirm. It could also be kidney failure. We suspect an early possible stage of COPD with a smoking history of 52.5 pack years, an elevated hemoglobin level, which is to compensate for it. And of course, our carboxyhemoglobin would also explain that. Review of the chest x-ray actually showed pneumonia and atelectasis. The pneumonia is likely linked to his history and could have been a result of his drinking, homelessness, or even linked to tuberculosis itself. The atelectasis could be a result of his physical condition, bruises, could be in pain, or a result of the pneumonia. For our hemodynamics and cardiopulmonary monitoring, the driving factors affecting hemodynamic stability in severe stages of tuberculosis is caused by alveolar consolidation and an increase in the thickness of the AV membrane, or AC membrane. Pulmonary shunt fraction is increased due to consolidation with pneumonia and atelectasis. Our delivery of oxygen to the tissues is usually decreased, but the body will compensate for it by increasing cardiac output. Our oxygen consumption, our AV difference, our O2 extraction ratio are all increased due to the body fighting off the infection, being in a hypermetabolic state. Our SvO2 is decreased because of more oxygen being extracted from the hemoglobin. And with our Swan-Ganz, our CVP is increased, our PAP, PVR, all increased due to pulmonary hypertension. Our wedge pressure is normal, our cardiac output is normal or increased, our stroke volume is normal, and our SVR is normal. And I'll lead it off to Pao for the plan.
Okay, guys. So for the plan of this patient, we have several plans that will be included to complete the treatment. And for that, we will start with bronchopulmonary hygiene. due to excessive mucus production and accumulation, sometimes associated with severe TB. A number of bronchial hygiene treatment modalities may be used to enhance the mobilization of bronchial secretions. Common treatment methods will be cough and deep breathing, chest physical therapy, percussion and vibration with postural drainage. We will have suctioning, mucolytic therapy, which include acetylcysteine along with the bronchodilator. And the next plan will be a respiratory isolation protocol, which is a technique required to reduce the risk of infectious agents that are able to remain suspended in the air. And patients who are hospitalized with active tuberculosis are kept in respiratory isolation, preferably in an airborne infection isolation until 3 sputum acid fast bacilli, AFB, smears are negative, which is taken over the course of 3 consecutive days. And the patient will be in monitoring negative pressure relative to the surrounding area. Also, special air handling and ventilation capacity of the room. Our other plan is the drug therapy protocol, which is consisted with several medications, which we have pyrazinamide, rifampin, streptomycin, and isoniazid, which is given over the course of 4 months. And then there is another 9 months that follows with 2 drugs, which are isoniazid and rifampin. And our other plan is oxygen therapy protocol. It's used because the patient has hypoxemia, so oxygen is required to decrease the work of breathing and decrease myocardial work. And the other therapy that we have is mechanical ventilation. For the settings, we will go with the VC-AC mode, which is a safe mode to start with. And with that, our VT will be will range between 465 to 620. Respiratory rate, we will start the patient with 14, with the PEEP of 5, FiO2 of 100%, and the flow titrate of 1:3 ratio. And the last plan will be smoking cessation intervention. It's a program that educates TB patients the harmful effect of cigarette smoke on health and specific information on smoking, which encourages them to quit smoking to improve the treatment and also to reduce transmission of the disease in the community.
Here we have a video of 5 things about tuberculosis.
All right.
Five things to know about tuberculosis, or TB. 1. Anyone can get TB. TB bacteria are spread through the air when a person with TB disease coughs, speaks, or sings. 2. TB is not a disease of the past. CDC estimates up to 13 million people in the United States have latent TB infection. People with latent TB infection do not have symptoms and cannot spread TB bacteria to others. However, without treatment, 5 to 10% of people with latent TB infection will develop TB disease at some point in their lives. For some people, the risk is much higher. 3. TB can happen anywhere. TB cases are found in all 50 states. 4. Treating latent TB infection is effective and can prevent the development of TB disease. 5. It's important. If you are at high risk for TB infection, you should get tested and treated if you have it. Together, we can end TB in the United States. Learn more about tuberculosis by visiting www.cdc.gov/TB.
All right. So that pretty much wraps up our video. And if you guys have any questions, just let us know through Canvas, and we will be up there. Before we head out, I just want to hand it over to Kat.
So as you guys noticed the background, so we do have the background for Mike for second semester. As you guys can see, I have the one for third, Pal has the one for fourth, and then Steven has the one for fifth. Unfortunately, we don't have a picture with the group for fifth semester due to the COVID. That's why we have the picture for that one. Thank you guys.
Thank you guys.
Thank you.